everyone, and welcome to today's Public Health Ontario Rounds presentation on leveraging the COMPASS study to examine the impact of the COVID-19 pandemic on youth health over time. My name is Rachel Laxer, and I'm an evaluation specialist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we start with today's presentation, I just want to mention a few housekeeping items. Zoom allows attendees to have the ability to customize their own view. You can do so in the right-hand corner of your own screen. Please use the Q&A pod if you have any questions during the session. We will save questions until the end of the presentation. The chat pod has been disabled to limit any distractions during the presentation. If at any point during the session you experience any technical issues, please email events@oahpp.ca. And I would like to state that as a moderator of the session, I do not have any potential conflicts of interest to declare. So it's now my pleasure to introduce the speakers for today's presentation, Dr. Scott Leatherdale and Dr. Karen Patty. Dr. Scott Leatherdale is a professor and university research chair at the University of Waterloo. His work focuses on advancing a systems science approach to primary prevention activities, evaluating complex population-level health interventions across multiple risk factor domains, and creating research infrastructure to facilitate large population-based learning systems in chronic disease prevention. And Dr. Karen Patty is an assistant professor in the Department of Health Sciences at Brock University. Her research examines how different contexts and exposures shape mental health trajectories across the lifespan, with the goal to inform more effective preventative practice. She is leading a mixed method study leveraging COMPASS prospective data and engaging youth to explore the impact of the COVID-19 pandemic and related measures on the mental health of youth over time. So I'll pass it over to Dr. Karen Patty or Dr. Scott.
Hi, Rachel. Thank you. I'll start and then I'll transition over to Karen at some point, and then it'll transition back to me. And welcome everyone to the presentation today. I think the hardest part for me is going to be remember to ask Karen to press forward on the slides for me. So we'll practice that. Next. Just before beginning, could you go back one, Karen? Sorry, with respect to acknowledgements, we'd like to thank our funders. We're fortunate where we've received a lot of funding to support this work. Specifically from the Canadian Institutes of Health Research and Health Canada and the Public Health Agency of Canada, and it takes a large team of people to make this happen, all of whom are listed here. Next, please, Karen. With respect to disclosures, aside from the funding that was listed in the previous slide for support for COMPASS to collect data, I've also received some research contracts from the Public Health Agency of Canada for some research specific to cannabis and COVID, and for our work in Nunavut, and from Health Canada with respect to vaping and cannabis. Next, or COVID and vaping, sorry. And then for Karen, it's primarily the grants associated with collecting the COMPASS data. Does anyone have any, I'm supposed to provide some time to let people ask questions with respect to the conflict of interest before moving on. While waiting, or if there's none, please note that the content was peer reviewed to ensure the scientific integrity and objectivity of what we're presenting here today. Next. And this document was not created by Public Health Ontario, it was created by Dr. Patty and myself. So to begin, I came out of the cancer world before transitioning to the University of Waterloo as a scientist at Cancer Care Ontario. And so I always like to put a little plug in here for cancer prevention at the beginning, because it's what guided the formation of COMPASS to begin with. And that's because cancer is the leading preventable cause of death in Canada. Next. And what's interesting with cancer is about 60% of cancer deaths can be considered modifiable because they're associated with modifiable risk factors. So if you consider tobacco, diet, obesity, physical activity, and alcohol use, are responsible for about 60% of the cancer burden, but those are also modifiable risk behaviors. And they primarily start during adolescence. So this is why I like to focus my research and the research of my colleagues, why we focus on youth populations. What's interesting is a lot of the time when people think of substance use and the modifiable risk factors, for example, physical activity, et cetera, that I just talked about with respect to the cancer burden, we know these are modifiable risk factors, and we often tend to think of them as things that are changed at the individual level, but we also know that characteristics of the school a student attends do shape the way students behave and how their behavioral development grows. For example, in the Canadian context, there's evidence that characteristics of the school a student attends or the community they live in independently impact their likelihood of using cannabis, tobacco, alcohol, or vaping. It impacts their eating behavior, obesity, physical activity or primarily inactivity, and also sedentary behavior. Next. So this means it's really important to understand what's going on in school environments. But what's interesting is even prior to COVID-19 coming about, we had very limited access to longitudinal data on youth. We really didn't have longitudinal data to be able to understand the developmental trajectories of youth as they developed over time. We also had limited cross-sectional data collected on an ongoing basis. But really to truly understand how these behaviors develop, we needed longitudinal data, and those weren't available in Canada. We also didn't have comprehensive inventories of what was actually going on in the school or community surrounding youth. So what programs or policies or built environment resources were in place and surrounding youth that impacted how they may have behaved or developed. These data weren't being systematically collected. And as a result of this, we actually had very little real world knowledge about how changes in programs, policies, or built environment resources actually impact youth over time. And this is what we like to call natural experiments. So it's trying to figure out, as real world changes to programs or policies happen, how do they actually implement or impact youth as they develop? And that was the impetus for forming the COMPASS study. Next. So COMPASS was designed to be a learning system focused on youth populations, and at the root of it, it was really to figure out, as youth developed over time and progressed through high school, what factors impact the development of their modifiable risk behaviors as they progress through school. And in order to do this, we had to design the system to collect population level longitudinal data from students as they progress through school. So this is important to highlight that it is longitudinal data we collect. We wanted the system to be able to evaluate the impact that ongoing real-world natural experiments had on youth. So as programs, policies, or resources in schools, communities, or provinces changed over time. We then wanted to take the evidence that was being generated and share it back with stakeholders in real time. And then we also wanted to be able to share the data we were collecting with researchers outside of our team, because we know how rare it is to have access to longitudinal data linked to program and policy data specific to youth populations. So since we had access to these data, we wanted to make sure that other researchers who had an interest could also be using it. Next. As a brief overview, COMPASS is a prospective cohort study. We started in 2012 and we currently have funding till 2022. And it's been designed to collect hierarchical longitudinal data from a rolling cohort of secondary schools and the students that attend those schools. We use active information passive consent protocols, which is a procedure. I'm happy to talk about this more in the questions, but it's basically where the parents or guardians are given information about the study and they have the opportunity to withdraw their child from participating in the study. This is different than the traditional active information, active consent protocols. And the reason we use passive parental consent protocols is with respect to the data we're collecting on substance use. You get much more accurate or less biased data doing that. We also use active assent for students where they have to consent to participating or they can drop out of the sample at any time. It's also important to note that we're a convenient sample of schools because of our active information passive consent protocols. To date, over 189 schools in Canada have participated in COMPASS, with more than 200,000 students completing the survey at one point in time or another. And to date, we've had 4 Canadian provinces and 1 territory participate in COMPASS. Next. The easiest way to summarize it is in a typical wave of COMPASS. Now we're seeing about 75,000 grade 9 to 12 students from around 150 secondary schools participating. These students are primarily located in the Ontario and Quebec samples, although we also have a sample of students in Alberta and British Columbia participating. We do use separate data collection protocols in Nunavut, so although we are collecting COMPASS data in Nunavut, we tend to treat it separately. Next. In order for COMPASS to collect the hierarchical data we need, really that's just a fancy way for saying we collect data at multiple levels. And what we're primarily interested in is collecting data on the school level environment and then from students themselves. And that's what I'm going to talk about in a little bit more detail here. And we use 4 tools to do this. First, we have the student level questionnaire, which is we call the COMPASS questionnaire. And prior to the onset of COVID-19, this was a paper-based Scantron questionnaire that was completed in schools during class time, and it could be completed in 1 classroom period. It collects data from students on a variety of topics. Everyone can read, so I'm not going to go through them in detail here, but focus on substance use, movement, behaviors, mental health, and some socio-demographic characteristics. And on the first page of the questionnaire, we also had 5 generic questions that were completed by students that allowed us to create a unique identifier for each student within a school that enabled our longitudinal data linkage. So to the longitudinal component of this is each student within a school created a unique identifier for themselves where we could link them over time. But at no point in time was there an actual name affiliated with the longitudinal data linkage record. So we were able to track students longitudinally, but at no point in time did we have to have the student's individual's name, which helped protect their confidentiality and ensures honest reporting. Next. After the onset of COVID and the closures of schools, it wasn't feasible anymore to collect paper-based questionnaires and whole school samples. So we transitioned to a Qualtrics-based online questionnaire where the University of Waterloo has an agreement with Qualtrics where we can use this tool. And the idea was basically to replicate what we were doing in the paper-based questionnaire, but do it online to facilitate, again, whole-based school samples. And these could be completed in person or online. So schools had the opportunity to provide students with an online link where they could complete it at home or outside of the school environment. Or we also had schools when they were in person that allowed students to complete it in class if they had computer devices while at school. So they had the ability to do this in person at school or online, but it was all web-based. We were collecting the same information as a paper-based tool, but since this was the onset of the COVID pandemic, we also obviously added some COVID-related measures, and these were specific to the form of curriculum delivery students were participating in, school protocols and responses. We collected student information on the impact of COVID-19 on their health, behaviors, and relationships, coping behaviors, etc. Next. So that's how we collect data from individual students in a school. We also wanted to know what's going on with the program and policy environment in each participating school. And that's where the school programs and policy questionnaire comes in. So for each of the domains measured in the student questionnaire, for example, substance use, mental health, movement behaviors, we have an online tool that's completed by the school administrators that are most knowledgeable about the school's program and policy environment. It's typically the principal or vice principal. And they provide us with information each year relevant to the presence or absence of programs or policies across each of the behavioral domains measured in COMPASS. And they also provide us with information related to any changes that have happened within that school in the past school year so that we can start to measure what programs or policies change so we can evaluate the impact of those policies on student behavior as natural experiments. As part of this being an online automated tool, we also annually provide the administrators with information with what programs or policies were in place previously. And we do this to assist with recall so they can remember what actually was in place in the previous year. But we also find that there's often new administrators at schools as principals change schools quite frequently. And this would provide any new principals with background information on what the school context was prior to them arriving. And in 2020, we also adapted this tool to now collect information on COVID-related programs and policies. Next. We were also interested in the built environment within schools, so we developed an application that our data collectors use called the School Environment Application, or COSI. And this was a direct observation tool where our data collectors, after they had collected the within-person student level data at a school, walked around the school and did these environmental scans of the food environment within the school and the physical activity environment within the school. They completed this questionnaire on one of their handheld devices, usually an iPad or an iPhone. But this also had the built-in capacity to take pictures of the resources as we're going through to the school to be able to get objective measures to supplement the subjective data our data collectors were collecting during the environmental scans. Next. However, unfortunately, as a function of school closures due to COVID, we haven't been able to collect the COSI data since the onset of the pandemic because the data collectors on our team aren't allowed within schools to collect these data. Moving forward, as schools open up again and protocols change in the future, we're not sure if we're going to be collecting these data, yes or no. Next. And finally, we're also interested in the built environment surrounding each school. And we link that to the data we've collected from students in the school program and policy data annually as well. And we get these data from CanMap Group Logistics. It's a built environment database that provides us with information on the catchment area surrounding each school. So we know the land use, whether it's parks, street connectivity, residential areas, etc. And then what's more interesting tends to be the enhanced points of interest data file, where this allows us around each school and the catchment area surrounding each school to be able to map the type and location of different opportunity structures. So things such as where fitness centers, fast food retailers, tobacco, alcohol, or cannabis retailers, etc. So we can adjust for these in our models to be able to start to understand, is smoking onset, for example, related to the density of tobacco retailers within a particular school catchment area. And we do this using ArcView GIS software, and we can create these buffers where we map this built environment data to any distance we like, but we traditionally do it to 500 meters and 1 kilometer, because that's typically the distance students will transition during a spare period at school or during lunch hour. Next. I'll stop here, and now I'm going to transition over to Dr. Patty.
Okay, thanks, Scott. Finishing off the last part of the Compass methods is how we share our results. As Compass is designed as a learning system, timely knowledge mobilization is a core component of the design, as particularly with schools and public health partners and policymakers. We use several strategies, and I'll touch on a few of these. For schools, a few weeks after we complete a school's data collection, schools are provided what we call a school health profile, or an individualized feedback report. It's designed for schools to be able to quickly and easily see at a glance how their students are doing in each health domain covered by Compass. We'll also provide comparisons to national or provincial norms or guidelines where they exist, so they can tell relatively how their students are doing. We're also able to show how their students change in each health domain across the years of their participation. So do they improve or decline in each health behavior over time? It also includes some suggestions for evidence-informed policies, programs, or other changes that schools can make. The schools report using these health profiles for their school health planning needs. We'll also provide board level reports, as many decisions are made at the board level, and public health partners as well can receive a report within their area. We'll also meet with schools and public health partners to go through results, identify priorities, and decide together on some actions that might make sense for their context. To further enhance the use of school data and to promote changes, each school is also provide a Compass knowledge broker. They follow up with schools to help interpret their reports, provide additional data, identify priorities, and decide on some actions based on their context and needs. Then they'll help connect them to any resources needed to help mobilize change. We can then evaluate any changes that are made in the next cycle of Compass and tell schools if there were any improvements or not. And that's how this forms a learning system. And some other ways that we share knowledge is, of course, on our website. You can see the website for various results. We have a data visualization portal at the high level that was funded by CPHA. We use social media, Twitter, primarily for school, their policymakers, other researchers, community organizations, and so on to share results. And then for youth, we have a new Instagram campaign. And it was youth, a group of youth who identified Instagram as the key way they thought to reach youth. They've identified results within Compass that they believe youth would be interested in hearing, and they've developed some posts. So with youth, we'll be evaluating this campaign. We've also developed some videos that you can see on YouTube. And then we use traditional academic means, of course, to share our results. So that's the design of Compass. Based on the design, basically, what can we use this data to answer? We can treat data either cross-sectionally, repeat cross-sectionally, or longitudinally. Cross-sectionally, we can look at what schools or school contexts are associated with higher risk, what risk behaviors or outcomes co-occur. And then with the repeat cross-sectional, we can look at population level or secular trends over time. So for example, has cannabis use increased since legalization? Has depression or anxiety changed since the onset of COVID? And we'll be sharing some of those results today. And then using the linked longitudinal data, and this is the real value of COMPASS and how it differs from other youth studies of comparable size, that we can look at these health trajectories as youth go over high school. We can get at what factors predict different trajectories at the individual or school or contextual level. We can get at the temporal sequence, what comes first. And then the primary goal of COMPASS is to be able to evaluate what Scott talked about as natural experiments. So whenever a new policy or program or other change is made at the school or at the community, provincial or national level, we can look at this pre-post individual changes in student health behaviors and outcomes. And then where possible, we can use what is called a quasi-experimental design, which provides robust data when random assignment to groups is not feasible or ethical, as is often the case, where we can use similar schools that are not impacted by a program or policy as comparison groups. So we're using this design to evaluate the impact of the COVID pandemic and related changes, different school protocols on student health over time. So getting into that, to robustly evaluate the impact of the COVID and response measures, we're able to leverage this linked data from the pre-COVID waves to provide a baseline and evaluate how students within student change during the different phases of lockdown. And then moving forward, are these changes sustained as we move into recovery from the pandemic? So last spring, after schools closed in March, we shifted online and collected data from over 9,600 students at 51 schools in Ontario, Quebec, and BC. And this was primarily between May and June of 2020. We've continued to collect data over the current school year and this was from over 130 schools in the 4 provinces. Next year, again, we'll collect data as we hopefully move towards recovery to look at sustained change. So while our last spring data sample within the early phases of the pandemic was a little bit smaller than we're used to, as far as I'm aware, this is the largest prospective study with pre-COVID data and during COVID data on youth health in Canada. Most studies we have are cross-sectional, or we lack is pre-COVID data, which is necessary so we can tell how student health has changed, how has it changed based on pre-COVID characteristics, and if any changes are sustained over time, or will student health behaviors and outcomes return to pre-COVID levels. We also know there's potential for latent effects that it can arise later. So this is why we need these ongoing prospective data to get an accurate picture of the impact of COVID. We will look at how these changes differed based on individual and school and surrounding contextual factors, different school protocols, provincial differences, and individual risk and supports, looking at health inequities. So we need these pre-COVID data waves as well, because we can't interpret any change during this time as due to COVID. We know that many changes occur over adolescence as a period of development. We need to know what changes we'd expect to see over time in adolescence and see if these changes, the magnitude or direction of change we see related to COVID differs from what we would expect to see. We also received a Sick Kids Foundation CIHR grant to leverage this prospective data specifically to focus in on the effect of youth mental health over time using a mixed methods design. We're currently collecting qualitative data to be able to dig more deeply to understand and provide context to the quantitative COMPASS data. Postdoctoral research fellow Dr. Nagin Riazi is leading the qualitative strand and has been interviewing youth across 4 provinces on their experiences of COVID and specifically related to school closures, reopenings, and different school protocols. In informing this study throughout, we've established a youth ambassador committee with 10 youth across the 4 provinces who have so far informed our research questions, our interview script, and will help us in interpreting data and in knowledge dissemination to ensure that results appropriately and fully reflect youth experiences. And then PHO has some poll questions for you, so I believe they'll share those in the chat. And then I'll throw it back to Scott.
Thank you, Karen. I'm just trying to get rid of my poll question in front of my screen there. Thank you. Before I go over some of the preliminary results, I just want to highlight something that's really important through this work too, through the COVID period. I've been involved with school-based surveillance of youth for about 15, 20 years now, and been involved with multiple surveys collecting data from just over 1 million youth in Canada. And it's an incredibly challenging domain to try to get access to schools and to get access to students for their data. And one of the things I think that's important to highlight from this is we've been working so closely with our schools and teaching them the value of longitudinal data and working with them with the different knowledge products Dr. Patty was talking about, like the school feedback reports, where we feel like we've got real buy-in from schools now, where they're really interested in working with us because they know we have a dedicated interest in helping them use the data to inform what's happening within their school-specific context. And I think this was really demonstrated where in March of 2020, when schools were forced to close due to COVID, that was a huge burden on schools in the province. And I'm sure the last thing they wanted to do was to be participating in a surveillance-based system that required extra time and time from their students to provide data. The fact that we were able to collect data from 9,600 students at that time was actually driven by the participating schools. They approached us and said, well, just because schools are closed, that doesn't mean we want you guys to stop. What are the options moving forward? And that's when we transitioned to the online tools. And I should have mentioned this before. And it was an interesting aspect of our team where within a 1-month period, we were able to completely transition all our tools to an online format that was safe and secure. We received all our ethics protocols and clearances in that time, and then had work and buy-in from the schools that were still interested in participating to use this new format that they weren't completely comfortable with at the time. And I think that's a testament to how valuable these data actually are to the school-based stakeholders that are participating in Compass. And I think that's important to highlight. We're a bit biased with our samples, where we're used to having samples in the 50, 60, 70,000 participant area, where we see a sample of 9,600 is quite small for what we were doing at that point in time. But then relative to other surveys that exist in Canada, even the 9,600 would still be one of the largest. So now moving on to some of the preliminary results during the initial COVID-19 pandemic response period. Before going into this, I do want to highlight what I'm presenting right now is only the repeat cross-sectional data only. We're not presenting any of the longitudinal evidence here. That's stuff we're working on outside of this, and it wasn't at a position where we just literally last week finished our data collections for this year's wave. So we just didn't have time to prepare that, but we're happy to share some of the results we have looking at this as repeat cross-sectional surveys. In terms of with our national data, I will present some data a little bit later that's specific just to Ontario. But this is how these data are broken down. So it was data collection cycles before the COVID pandemic period. And then you can see the 2019-20 BC data wave is before the school-based closures in March 2020, 2019-2020. So that's the data we collected using the traditional format before the COVID pandemic. And then the data from 2019-20 AC is the data that were collected after the COVID pandemic started and the closure of schools. So you'll see in all the figures I'm presenting, what you're probably really the most interested in is what happened between 2019-20 BC and 2019-20 AC. Next. So let's start with vaping. because this is something that was becoming much more prevalent in the youth population over time. And you can see here that there was from 2015 forward, there was an increase in current vaping among youth. Then there was a slight decline at the start of 2019, 2020, but you can see at the onset of the COVID pandemic in the spring of 2020, the frequency of current vaping declined dramatically. You can also see over the same period of time, however, there was an increase in occasional vaping. Next. If you consider this as the total frequency of vaping, so both combining occasional and current vapors, you can see that there was a fairly steady increase over time in the overall frequency of vaping, primarily driven by current vape use. But again, at the start of the COVID pandemic, this declined the overall frequency of vaping, where the number of current vapors decreased and occasional vaping increased. We don't want to read too much into these data, but I would likely assume that this has something to do with the function of students being at home, and with the lockdown of students not being able to go about their day-to-day activities, it was just harder for vaping activities to be performed when they were in their home environment relative to when they were out and about in the school and the community environments. And this will be the same kind of conclusion for a lot of the substance use behaviors we're talking about here. Next. If you consider cannabis vaping, so not vaping of nicotine-based products, but cannabis vaping, the prevalence in the population of our sample was fairly low to begin with. It typically peaked around between 6 and 7%. And then you can see there was a slight decline before the onset of the COVID pandemic. And then with the start of the COVID pandemic, a decline to about 2.5% of students in that sample reported that they were vaping cannabis in the past year. With respect to binge drinking, so in Compass, binge drinking is defined as students having 5 or more drinks in one occasion. You can see that binge drinking was relatively stable in the student population we've been following over time, where although it was declining slightly over time from about 21% of students in 2015 to around 16, 17% in 2018, 19, 2019, 2020, you can see at the onset of the COVID pandemic, there was a fairly sharp decline in the prevalence of students who reported that they were current binge drinkers. And current binge drinking, again, 5 or more drinks on one occasion, where the current is doing that in the previous month. You can see occasional binge drinking, again, fairly stable, and then declined at the onset of the COVID pandemic. Next. If you look at the overall frequency of binge drinking, again, slight declines in our samples over time, and then a sharper decline at the onset of the COVID pandemic, primarily driven by declines in current binge drinking. With respect to cigarette smoking, you can see smoking among students in our sample was rather low throughout the cohort. So it was at its peak in 2015-16 at just under 12%. And then there was a fairly steady decline in our sample overall over this period of time for current smokers. Occasional smoking has stayed fairly consistent. And then at the onset of the COVID pandemic, you can see current smoking declined again, where about 3.8% of respondents in that sample reported that they were current smokers, whereas occasional smoking remained fairly consistent even at the onset of the COVID pandemic. In terms of the overall frequency of cigarette smoking, a gradual decline over time. The good news story here is the decline is primarily being driven by a decline in the prevalence of current cigarette smoking in our samples. And then you can see at the onset of the COVID pandemic, the frequency of current cigarette smoking is incredibly low, in that it's really being driven by occasional cigarette smoking in that sample. With respect to cannabis, and this was a large concern for people with the legalization of cannabis in adult populations in Canada in 2018, but you can see here our data, and we have a lot of publications on this that are fully adjusted models. This is just the cross-sectional data presented here unadjusted. You can see that cannabis use has remained fairly consistent, and if anything, it's been declining over time in our population, where current cannabis use went from about 13% or just under 14% of students to the early COVID pandemic period. It's down to about 6.7% of students were reporting that they were current cannabis users, whereas occasional cannabis use remained fairly consistent or stable over time in our sample. In terms of the overall frequency of cannabis use, so that's both current and occasional, again, you can see a declining trend over time, even when you explore the onset of cannabis legalization there in 2018. You can see that it did not have a profound effect on students in our cohort. And then you can see there was actually a larger effect from COVID, early pandemic COVID response. Next. This might be a little bit more interesting. These are Ontario-specific data, and the one difference here from what I just presented to you is I'm presenting, again, it's repeat cross-sectional, and it's data from 2018-19, so before the COVID pandemic. Then I'm presenting the same data I did in the last slides, but from the Ontario-specific sample only of 2019-20 pre-COVID data collected before the school-based closures. Then the 2019-20 early COVID period data. Oh, go back one, Karen, sorry. Which is the data collected right at the start of the COVID pandemic. Then in the blue, what we did here is we pulled the data that we're collecting in real time this year from the field to say what are we seeing in these trajectories of kids now that the COVID pandemic has been in place for a year, the restrictions have been in place for a year. So it's the data we collected in the fall, so data we collected in December of 2020-21. And then data we collected this spring that were collected between February and April to see what's happening with students. And again, this is specific just to the province of Ontario. And you'll see, even though I said in the last slides that things were generally declining, you'll see a slightly different story when we show you the follow-up data for what's been collected this year. Next. So with respect to vaping, and one of the points I should have raised with this, our school stakeholders were interested in looking at these data based on whether or not students were primarily participating in in-person learning for their schooling or for online-based learning during the pandemic period. So students could opt to be online only, or students could opt to be in-person for going when schools were actually closed. And you can see here that the frequency of students reporting current vaping was typically lower among students in online learning versus in-person learning. So what's really interesting is during the early COVID pandemic period I just presented to you before, there was a decline in current vaping, but then you can see it's actually bounced back quite well in the 2020-2021 period among students who were back to in-person learning at school. But then among the students who were primarily learning in an online environment, it remained fairly stable at the lower prevalence rate in this sample. So for my earlier assumption where we don't want to overstretch because we're not presenting anything from adjusted models here, you would want to assume, or I think it's safe to assume, that students being at home with parents or guardians where they couldn't go out and about in the community has a pretty good protective effect on their substance use behaviors relative to the kids who are back outside of the home environment and back in the school environment and able to socialize. Next. With respect to cannabis use, we see the same thing. So prior to the onset of the pandemic, it was fairly stable. Then there was a decline. And then during the data we collected this year, you can see that the frequency of students reporting current cannabis use, so that's past month cannabis use, is typically lower among students learning online versus students learning in person. With respect to current cigarette smoking by learning modality, it follows a similar pattern, where you can see the frequency of students reporting current smoking is lower among students learning online versus in person. With respect to binge drinking, again, and this is 5 or more drinks on one occasion for binge drinking, this is something where we see something very different than what we saw with any of the other substances we looked at. Where consistent, the frequency of students reporting current binge drinking is lower among students learning online versus in person. But you can see here in the spring COVID period of 2020-2021, so the data we collected between February and April, almost 1 in 4 students reported current binge drinking. This is much higher than what we saw previously. If we move on to some of the mental health data, you'll see a different story here where for substance use, typically the students learning online seem to be protected or have a lower frequency of use relative to students learning in person. For the mental health indicators we're going to talk about now or present some data on, you see the opposite story happen. So what you can see here is over time prior to the onset of the COVID pandemic, average anxiety symptoms. So this is a score on the GAD-7 scale, which is a measure of anxiety, which ranges from 0 to 23, that the scores were typically fairly stable at around 7. But then you can see since the onset of the COVID pandemic that anxiety has actually increased among students in Compass, but anxiety scores are typically higher among students learning online versus in person. Next. If we look at clinically relevant anxiety symptoms, so rather than just what their score is on the scale, but clinically relevant symptoms, where this is on their GAD-7, they have a score greater than or equal to 10. Again, you can see prior to the onset of the COVID pandemic, it was fairly stable, where around 29 to 30% of students reported having clinically relevant anxiety symptoms. But since the onset of the COVID pandemic, there's been an increase overall in students reporting that they have clinically relevant anxiety. But the symptomology is typically higher among students learning online versus in person. And this is quite large when you think during the spring of this year, that around 44% of students in our sample at that time who were participating in online schooling, reported having clinically relevant anxiety symptoms. Next. With respect to depression, so this is a depression scale measured on a range of 0 to 30, where higher scores represents higher depressive symptoms. You can see, similar to anxiety, prior to the onset of the COVID pandemic, it was relatively stable. And then since the onset of the COVID pandemic, depression in the student population has increased. But you can see here that depression scores are typically higher among students learning in an online environment versus students learning in an in-person environment. And the gap seems to be widening. That's something interesting too, I should have stated before when you look at the most recent data we've collected. If you look at with respect to clinically relevant depression symptoms, so again, this is having a CSD-10 scale score of greater than or equal to 10. You can see it was fairly stable over time prior to the onset of the COVID pandemic, although still quite high in the prevalence of student populations. Depression's been a problem in the student population, I think, for a while. It's got remarkably worse since the onset of the COVID pandemic. And you can see here that clinically relevant depression symptomology is substantially higher among students learning in an online environment versus an in-person environment. Where if you think of this for the data here, the 59% reported for 2020, 2021 this spring, that represents a 59% of the students in our sample that were learning online reported having clinically relevant depression symptoms. That should be a cause for concern for a lot of people. Not saying that the 44% for students in participating in in-person learning shouldn't be cause for concern, but you can see a large bifurcation in the learning modality and clinically relevant depression symptomology. Next. So we could probably sit here I think Karen and I could sit here for days presenting data to everyone, but we're happy to have people reach out to us and contact us if they want to learn more. We have gobs and gobs of data available. And what we really want to do is to be useful to stakeholders and researchers who want to use these data. So one of the things we do is we make Compass data available to any other researchers or stakeholders who want to use the data and are willing to collaborate. This is unlike a lot of the other data collection systems that exist. There's substantially more here than we can answer. So we want to work with people who want to use the data to advance the agenda of promoting youth health. We can share data, either cross-sectional waves of data, repeat cross-sectional data, or linked longitudinal data files through secure file transfer systems that we have available to us at the University of Waterloo. And because we never collect any information on individual student names, we do this as de-identified data, so there's no risk of any of the HIPAA rules with respect to our sample. It's interesting, the only names of students we actually have in our cohort are the names of students who aren't allowed to participate in this study, where their parents or guardians didn't allow them to participate. We're also willing to share our tools and resources where possible. So we have a fairly large team of collaborators now scattered across Canada, many of whom are biostatisticians. So while we're sharing our data with interested researchers or stakeholders, we also provide the opportunity if there's a particular person who wants a question answered and wants to collaborate, but doesn't have the capacity maybe on the biostatistics end to do some of the complicated modeling that's involved with these data. That's a resource we can provide for interested stakeholders, and we do this free of charge because we don't want the cost of these kind of things to be a barrier to people trying to get the answers to questions they need. Across everything we're doing, we always prioritize student projects and trainees. When I first started in this field, there were very few researchers doing primary prevention research with youth in Canada. So one of my missions for my career has been to try to build the capacity of trainees in this across Canada. So across all the topic domains and across all the research questions we could answer, we always try to prioritize student trainee projects on those topics. So for example, if an established researcher wants to work on a current topic area, but that's an area a trainee's interested in, we try to prioritize the trainee getting the topic and then linking that trainee to that investigator so the investigator can act as a mentor for the trainee. We're also interested in collaborating with anyone who's interested in any future funding proposals to either help maintain the ongoing collection of data in Compass. It is a prospective cohort, so we need to keep collecting data on an ongoing basis, or if we miss a wave of data, it kind of defeats the purpose of it being a prospective study. But there's also the opportunity for future funding proposals to explore different areas. For example, we have some people we're working with now who are trying to build in some machine learning models to the data we've collected, and there's been funding proposals put forward in those areas to build our capacity in that domain. Basically, we're willing to work with any interested researchers or stakeholders who are wanting to work with us to advance practice-based evidence to promote youth health. So I'm going to stop there. I think, Rachel, leave some time for questions.
Yes, thank you very much, Scott and Karen. We're going to move now to the Q&A pod to address some of the questions. So for those of you that have questions, please enter them into the pod if you have not already had an opportunity to do so.
So for the first question that I'm seeing, are the data presented, published, and citable? I don't know if I'd want to be citing these data right now because it's completely unadjusted models. We're just showing frequencies of what was happening across waves, again, in completely unadjusted models. Our team is currently working on a series of publications, some of which have been accepted, some which are in the current revise and resubmit stage or being produced, that present a lot of these data in more detail where they are adjusted. I think it'd be much more reasonable to cite those papers as they come out, and we share all of those via as papers come out with the data we're presenting on social media and through our websites and things such as that. Or if people are interested, you can reach out to us and we can make sure that as something comes out, we can share it with you. The presentation here, we're happy that people can see those data, but I just would put the caution if people were to cite anything from it to make it clear that they are unadjusted frequencies.
I should also mention that we did write a collaborative report, Public Health Ontario and Compass, on the health behaviors of secondary school students during the first wave of COVID-19 that you can find on our website and on the Compass website. Yeah,
we'd be much more comfortable with that being cited than the data presented here. Does the COVID sample differ a lot from the regular Compass sample? I would say the sample that we saw in the immediate COVID period of 2019-2020 does look a bit different. There were more females in the sample, and there were some differences in terms of what jurisdictions or the spread of jurisdictions and schools, I guess, participating. So it does look different that way. The data we collected this year looks more like what our traditional samples were. So that's why I'd get a bit nervous about presenting anything that was unadjusted from that sample, because there will be bias in that sample that was collected in the immediate post-pandemic period.
Okay, so there's another question for you too. There is somebody wondering if the data are available specific to smaller jurisdictions in Ontario, such as municipalities or school board level.
Great question. one of the first things we do is schools are the owners of their data. So we ask all schools to sign a data sharing agreement if they want to share their data. And if they have, then we can share it at a smaller level rather than with the aggregate data set. We do have some jurisdictions where we can provide complete school board census level data in some school boards. And then we have some other school boards where there probably wouldn't be a sufficient number of schools to be able to do that. It'll vary across municipalities and school board regions in the province, but there are some cases where it would be feasible to provide data on a board level or at a regional level, and there's other jurisdictions where it might not. So what I'd suggest there is if you're interested for a particular jurisdiction is to reach out to our team and we'd be happy to say if it's feasible. For example, because we're not a representative sample, that's why we can't just pull everything from every region. We're not in every municipality in the province. Whereas say in the Quebec sample, we have a complete census of schools for the entire Quebec City region participating. So there's different things we can do with our data for regional analysis with the Quebec sample than say we could within Ontario.
Great. I'm just going to pop in my own question here for a second before I move on to others. I'm just wondering how you think education and or health ministries or other organizations in the province are planning to use these data.
Ooh, that's a great question. Maybe I'll answer it in two parts. It depends on the jurisdiction. So for example, in Quebec, as soon as our data are available each year in our Quebec sample, representatives from the Ministry of Education and the Ministry of Health meet with our team in person to basically sit down and go, what do we need to plan from this moving forward? Where health and education are working quite closely together to figure out how to move a mandate of protecting youth forward. In other jurisdictions, so for example, in Ontario, it's been a bit more of a challenge to get education interested in the data or to get public health or say health at the provincial level interested. So we've had to do more of a grassroots thing of working directly with schools and directly with interested public health unit staff to share the data that way to get them more interested. I don't know if there's something you want to add there, Karen. You've done a lot of work on the engagement side of things.
I think regionally, there's a lot of interest, as you say, within public health at the ministry level. It's been a bit more challenging with Ontario than other provinces.
Your next question, first it leads in with fascinating work. I've always heard about the COMPASS study from my time with Brock. So when collecting this type of data, can you assess the data quality? How much would Questionnaire vary if a sample student were to fill it out a week later?
That's a good question. So we've done some validation work with our tools. So we know, like for a bunch of our core measures, so for example, smoking, we know the reliability and validity of our smoking measures, of our physical activity and sedentary behavior measures. It's not something where we have the capacity or the feasibility to do this on an ongoing basis because there's not enough funding to be able to dedicate the time to doing the constant one-off validation studies that would be required within our sample. It's also a huge extra burden on participating schools to do these kind of validation-based samples. So being upfront and honest, our data are consistent with the quality of data you get from other school-based surveillance tools that are in place, and we do work as we can to validate new measures if they're required, but it's not something we're doing on a frequent basis. For the volume of funding we have to support this work is pretty modest and tight when you think of the volume and scope of data we're collecting. So we're the largest school-based surveillance system in Canada. We're the only one that's also collecting linked program and policy data across multiple domains. And when you compare us to the federally funded surveillance systems that collect about a third of the data, none of the program or policy data, our budget is about a third of what they have available. So while we'd love to do more of that work, and we do have people on the team who have that expertise, it's just not something we have the feasibility to do. But it's why we do put a lot of thought into which measures we're using. For example, on the mental health side of things, the data that collected from the GAD-7 and the CSD, there's ample evidence of the validity and reliability of those tools in use-based samples. So us continually validating may not be the most robust use of our limited resources, but I do appreciate the question. It is something we consider a lot about.
So the next two questions are I feel like you can probably answer them together, but we have two people wondering, so is the COMPASS study collecting data on disordered eating symptoms from the COVID sample? And then there's somebody wondering if there is consideration to embed protective factor data collection, such as recreation, sense of belonging, connection to caring adults, etc. So these are just questions about data collections and what you are collecting in your survey.
You answer the first one, Karen, and I'll answer the second.
I can feel both of those. First, simply no, not exactly. What we have been asking is how they perceive their weight, if they are trying to lose or gain weight or maintain their weight. We ask about their dietary intake and dietary behaviors, including skipping meals. Recently, we added across this school year, we've been asking about whether they're restricting food in effort to change their weight in some way. So we asked minimal questions, but not specific to disordered eating, but that is an area that I would very much likely to add some measures.
I was just going to say, we just recently submitted a funding proposal for renewal funding, and one of the things we proposed there was a more modular system where schools can also pick specific topic areas outside of what we're currently doing to collect information if it's a priority to them, and one of the topics was around disordered eating. In terms of the positive information or the positive measures, yes, we do collect a variety of other measures that we didn't talk about here. So things around school connectedness for students, participation in organized recreational sporting activities, social support from family and peers, et cetera, et cetera. We just didn't have time to present. We just gave an incredibly small snapshot of what's available here and what we presented, but we do try to collect some of those data as well.
Yeah, we'll be interested to look moving forward. We're trying to explore right now how the impact of COVID differs based on that home environment they have in terms of was their happy home life? Can they talk to their parents with friends about their problems? Are they getting along with their parents during time? Is there economic concerns within the household related to COVID and so on? So we will be able to get at the home environment and how impacts differ, as well as the school environment in terms of school connectedness, or were they bullied at school? Potentially those who had a more negative school experience might have preferred online, or to kind of sort out some of those differential impacts we might be seeing.
So somebody asks, what advice might you have to the education system moving into the fall with schools reopening?
One of the things, there's a lot, but I think the high level one I'd say is based on what we're seeing in a whole bunch of our preliminary models moving forward, is for schools, what they can see as a modifiable behavior that they have control over, a modifiable outcome they have control over, is really focusing on the school connectedness aspect of what we're seeing. Students are feeling less connected to school, which makes sense. And in all the predictive models we've been doing in different topic areas, school connectedness seems to be an important driver of substance use, mental health, physical activity, general well-being. So if I could only give one message to school stakeholders, it would be when schools transition back in the fall, do whatever you can to make schools feel like students feel like they have a sense of belonging to their school and that they have a strong connection to the school environment. That's right in the wheelhouse of schools, but it also has these trickle-down effects on being a protective factor or a positive factor across multiple domains that impact youth. I think that would be my assumption at a high level.
Yes, I support that. We even see potential protective factors for those who their home environment has risk factors, for those who do have a strong sense of school belonging. And then within some of our qualitative data that we're over halfway through our interviews now, some of those details are coming out of their experience of schools and kind of enhancing their communication or the back and forth. Closing, reopening, and kind of feeling like they're the last people to hear about it or be considered in those decisions.
That leads nicely into this next question. Maybe you can provide some speculation, maybe not, but why do you think online learning students are more anxious than in-person learning?
If I had to make an assumption based on the data I've seen, so we've also looked at other indicators based on online or in-person learning. And it seems like for the students who are participating online, they're also the students who are more likely to report that they were really interested in going to college or university next year. Relative to the students who were in person, there was more indifference there on what the next steps were. So I think part of the anxiety may come from you don't have the social supports around you being in a home environment all the time. I have 2 young kids at home right now who've been stuck with me and my wife for the past few months, and I'd say they're more anxious just because they're sick of being around us all the time. But there's also this whole larger picture of if they're planning to go to college or university next year, and our data also said those were the students where marks were substantially more important to them. I think that could be creating a lot of stress and anxiety where you also then don't have the social network around you to support you. And how do you deal with that? How do you think about that? You're not getting access to the same resources to talk about the processes of applying for next steps and things such as that. Again, that's just speculation. Would love to, trust me, I think Karen probably has a plan for a huge amount of work to figure out what's actually going on with anxiety in kids in the sample. Because when you see that the data we're presenting, even just raw and adjusted numbers, it is not painting a very good picture for what's happened in kids. What I'm really curious to see is when we collect our data next year, is any kind of rebound effects. Because say if all students are back in person next year, was there any long-term protective effect for, say, substance use of actually being online, because that was protective, it seemed like, relative to kids in person? Is there a long-term trickle-down effect for that? Or if everyone transitions back to in person, is there any sort of rebound or protective effect on anxiety and depression? Do the kids who were online when they transition back to in person see any benefit? I think that'll be some of the interesting stuff we can look at next year as well.
Great. Okay, well, thank you. It's now 1 o'clock. So as we wrap up today's PHO round session, I would like to thank Scott and Karen for presenting. I would also like to thank everyone who joined us for today's session. It's really great to see such strong virtual participation during such a challenging time for healthcare professionals and public health. To access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Lastly, you can expect to receive the brief and anonymous PHO round survey for today's sessions shortly. Please try to complete this to help us improve our programming. Thank you and have a wonderful day.